Welcome to the Deep Dive. Our mission today is all about mastery. We're going to take the foundational concepts of trauma management, drawing exclusively from Chapter 26 of Bailey and Love's Short Practice of Surgery, and really break them down into something you can use for revision and for your clinical practice. So if you're about to step into a trauma rotation, prepping for a big exam, or you just want to understand the absolute core principles that govern how we manage acute injury today, this deep dive is for you. At the very heart of all of this, there's one non-negotiable truth. The sheer magnitude of the global injury problem has to be managed under the critical, uncompromising constraint of time. So today we're going to unpack that timeline concept, the systematic ATLS approach, that crucial formula for assessment, and of course, the big surgical debate, early total care versus damage control.
It's absolutely essential we start there, not with the procedures, but with a real clarity on the scale of this challenge. Trauma, at its most fundamental, is an injury from energy transfer.
Right, energy. So that could be anything.
Anything. Chemical, thermal, ionizing radiation, or, the most common one, mechanical. And what really dictates how bad it is, it's the magnitude of that force, the nature of it, and, crucially, how long it was applied. And when you hear clinicians talk about major trauma, we're being specific. We mean a patient with injuries to more than one body region or organ system, or, and this is the key metric, an injury severity score, the ISS, of more than 15.
An ISS over 15.
Exactly. But you have to remember, major trauma gets all the attention because of the resources and the high mortality, but it actually only affects about 15% of all injured patients who come through the door.
That's a fascinating statistic. So that 15% really drives the entire system.
Yeah.
But the day-to-day work is different.
Very different. The bulk of it is patients with low ISS scores, between 4 and 9. Think of an isolated limb fracture. But our systems have to be built to handle that critical 15%.
Okay, so let's establish why this systematic approach we're about to talk about is, well, a necessity, not a luxury. Let's talk about that magnitude. This is a profound public health crisis, isn't it?
It really is. Look at the numbers. In Western industrialized countries, trauma is the single largest cause of death and disability in children and young adults. Period. The World Health Organization estimates 5 million injury fatalities worldwide every year. That's about 9% of all global deaths.
Hang on. I just want to pause on that number because it's staggering. 9% of global deaths. The WHO explicitly says this is 1.7 times higher than the deaths from malaria, TB, and HIV/AIDS combined. So you take 3 of the biggest infectious diseases we fought for decades, put them together, and trauma still kills more people in this demographic. That just completely reframes the problem, doesn't it?
It has to. It moves trauma from being, a surgical problem to being one of the most critical global health challenges we face. And the causes are tragically predictable.
Let me guess. Road traffic accidents.
Road traffic accidents, falls, and intentional violence. Together, they account for almost 2/3, 64% of all trauma fatalities. It's a consistent pattern of energy transfer.
So with all that complexity, we need a way to talk about it, to standardize it. And that brings us back to the injury severity score, the ISS. You start with the abbreviated injury scale, or AIS, which is basically a dictionary with over 2,000 injury codes. Each one gets a score from 1, which is mild, to 6, which is
maximum, a universally fatal injury.
And how do you get from those individual scores to the overall ISS?
Right. So here's the detail you need for revision. It's not just adding them up. You take the 3 most severely injured body regions, not individual injuries, but regions like head, chest, abdomen. You take the highest AI score from each of those 3 regions, you square each of them, and then you add those 3 squares together.
Okay, so if you have a head injury scored at 3, a chest at 2, and an abdomen at 4.
Then your ISS is 3 squared, which is 9, plus 2 squared, which is 4, plus 4 squared, which is 16. So 9 plus 4 plus 16 gives you an ISS of 29. And since that's over 15, that patient is officially classified as having major trauma. It gives us a common language for anatomical severity.
And the real-world data just hammers this home. You look at the road traffic accident data, the source uses UK and EU figures. In the UK in 2019, you had over 153,000 casualties. Of those, nearly 26,000 had severe injuries, and over 1,700 died.
And the EU data from 2020 is really interesting. It was 42 deaths per million people. Now, that was down from 67 a decade earlier, which is good. But the text points out this unprecedented drop between 2019 and 2020.
The pandemic?
Exactly. The massive sudden reduction in fatalities was a direct result of severe traffic restrictions. It was a kind of tragic, natural experiment.
It's definitive proof. It links exposure, just the volume of traffic, directly to trauma incidents.
Yeah.
But the difference between countries is also huge. Norway had only 17 road deaths per million, while Romania had 85. That's a five-fold difference. How?
It's policy, it's infrastructure, enforcement, vehicle safety standards. The low rates in places like Norway and Sweden are the result of decades of investment. The high rates elsewhere show that our clinical problem is, at its root, a societal problem.
And we haven't even touched on the cost for those who survive.
Well, the cost is staggering because a huge proportion of survivors, around a third, face long-term or even permanent disability. We're talking chronic pain, loss of function, inability to work.
The direct medical cost in the UK is estimated at 3.5 to 4 billion pounds a year. But that's just the direct cost, right? That's not the whole story.
Not even close. That's the tip of the iceberg. The indirect costs, lost earnings, welfare support, reduced quality of life for the patient and their family, they just explode the total societal burden. When we talk about investing in trauma systems, we're not just saving a life, we're trying to save a lifetime of productivity and quality.
Let's shift to a demographic that's becoming more and more of a challenge. Trauma in older adults. It used to be that polytrauma was the young person's game, high-speed crashes.
Yes, but that's changing fast. People are living longer, they're more active, and frankly, our diagnostics are better. We're using things like CT scans more, and it's revealing the true picture. Before, a lot of these injuries in older adults were probably just missed or written off as, part of getting old.
And this leads right into fragility fractures.
It does. The NICE data from the UK shows 500,000 new fragility fractures a year. 70,000 of those are hip fractures.
And the outcome for a hip fracture in an older person it's really grim.
It is truly sobering. For patients over 65 with a hip fracture, nearly 7% will be dead within 30 days. And most of the survivors will never regain their previous level of independence or mobility. This group represents a massive and growing burden on our healthcare systems.
So we have the sheer scale of the problem, and then we have these specific vulnerable groups.
And within that, our vigilance has to be absolute when we consider non-accidental injury, NAI, especially in children. While most trauma is accidental, you must always maintain a high index of suspicion.
There's a terrifying statistic in the source material about this.
There is. In 2/3, 66% of child deaths from abuse, that child had a previous interaction with health or social services where the seriousness of the situation was missed. It was just not acted on. That's why our responsibility as clinicians to see the pattern, to document it, and to escalate it is paramount.
Okay, let's move from the scale of the problem to the solution. And the solution is completely governed by this timeline concept. You called it the most critical philosophical element.
It is. Think of it like this. Time point zero is the second before the injury. The patient is at their normal baseline. Everything after that, the body's response, the injury's progression, our intervention, is on a clock. A race against that clock.
And in that race, there's an optimal time window.
Exactly. There's a window where if we intervene, we can have a radically positive effect. If we miss that window, the chance of irreversible damage or death just shoots up.
This urgency basically creates our categories for what to do. You have emergent or life-saving actions.
Right, things like a blocked airway, a tension pneumothorax, cardiac tamponade. These are problems you measure in seconds or minutes.
Then you have acute interventions.
That's about restoring stability, controlling bleeding, maybe some initial fracture stabilization.
And finally, the delayed or semi-elective stuff.
Yeah, that's dealing with the complications down the line. An infection, a fracture that won't heal. Important, but not an immediate threat to life or limb.
The hierarchy is simple. What kills first should be managed first.
It's as simple and as unforgiving as that. The time you have to fix a blocked airway is a tiny fraction of the time you have to save an ischemic limb. That principle is what's hardwired into the Advanced Trauma Life Support System, ATLS.
The ABCD hierarchy. Airway, breathing, circulation, disability. It's a direct operationalization of that time dependence principle.
It is. And operationally, that means the total time to manage a problem is the time to identify it plus the time to treat it. So to win, you have to ruthlessly shrink that identification time.
Which is why, in the ATLS primary survey, you just throw out the normal, detailed history and full exam.
You have to. The focus is on immediate detection, rapid prioritization, and efficient treatment in the tightest time frame possible.
This brings us to a really critical idea. Screening before signs.
Yes. This is crucial. You have to use the mechanism of injury and your initial findings to proactively look for things, usually with imaging like a CT scan, before the classic life-threatening signs actually appear.
Because if you wait for those obvious signs,
You've lost precious, irreplaceable time. The full-blown presentation means the damage is already done.
let's use the classic example from the book, the extradural hematoma. Patient gets hit by a car, they come in, they've got a cut on their head, maybe their GCS is 13, they're a bit confused.
Right. And that confusion could be anything. It could be a bit of hypoxia, they could have been drinking, it could be mild shock. So you face a choice. Do you wait? Do you wait for the GCS to plummet or for one of their pupils to dilate?
Which are the classic signs of a brain bleed causing massive pressure.
Exactly. Signs of impending cerebral herniation. But if you see those signs, it means the pressure is already so high that it's causing irreversible brain damage, or it's about to kill them. You've waited too long.
So the proactive approach is,
You see the mechanism, you see the slight confusion, and you get a head CT early, maybe as part of a whole-body scan protocol. You diagnose that hematoma before the catastrophic signs appear. That allows for prompt surgical decompression, and that is literally the difference between a good outcome and death or devastating brain injury.
that perfectly illustrates it. Relying on obvious clinical signs gives you insufficient time to respond effectively. You have to act on suspicion, on risk, not on clinical confirmation.
And that's the operational challenge. To do that, to get that patient from the door to the CT scanner to the operating room, requires immense resources. A dedicated trauma team, an available CT, an open theater, all ready to go 247.
Which is why we have level I trauma centers. It's not just a big hospital, it's a system designed to compress that timeline.
It's a whole system. It's a commitment. 24/7 specialist, coverage, neurosurgery, orthopedics, general surgery, all on site. Clear activation protocols. It's a machine built for speed.
But the timeline doesn't just stop after the first hour, does it? You talk about ongoing evaluation.
Absolutely. Trauma is dynamic. The primary survey is followed by a secondary survey, and then, often a day or two later, a tertiary survey.
A tertiary survey. Why so late?
Because missed injuries are a huge problem. As the patient stabilizes, as they're warmed up, as the sedation wears off, other things become apparent. A subtle fracture, a minor bowel injury. You have to keep looking, and you have to monitor trends. Is their oxygenation slowly dropping? Is their acid level creeping up?
You're looking at the curve, not the single data point.
Always the curve. A deteriorating curve demands a response, and often it uncovers a missed injury that's been quietly brewing.
So now let's get into the intellectual heart of this. The assessment. How you put the puzzle together.
Right. The goal is to build the best possible picture of the injuries. And you do that by combining three things: the mechanism of injury, the patient's pre-existing factors, and the injuries you've already found.
Mechanism plus patient equals injury.
That's the formula. And when it all adds up, when it's coherent, it helps you hunt for the hidden, covert injuries. But the real red flag, the moment you have to stop and think, is when it doesn't add up.
What would that signal?
It signals something unexpected, either an unknown underlying disease, like a pathological fracture through a tumor, or a deliberately concealed story, as in non-accidental injury.
So let's take an example. A passenger in a seatbelt in a head-on collision has fractures to their ribs, their sternum, their thoracic spine. That's the injury. The mechanism is massive central deceleration.
So automatically, the FOMINA tells you to look for other things. You have to actively search for a cardiac contusion, for a deceleration injury to the aorta or the liver, even if the initial scans look okay. The mechanism predicts the hidden injuries.
Let's break down the mechanism first. It's blunt, penetrating, or combined. You said it's like a roadmap.
It is, because you only find what you look for. With blunt trauma, you can have direct force at kick, causing a clean break right where the kick landed. Simple.
Or incorrect.
Indirect is much more complex. The damage happens far away from where the force was applied because the energy travels through the body. A fall where you twist can cause a spiral fracture at the ankle, but the clinician knows they also have to look for a second fracture higher up the fibula.
And the classic example of that is the dashboard injury.
The dashboard injury is the one every trainee needs to know. The knee hits the dashboard, the force travels up the femur to the hip, and causes a posterior fracture dislocation of the hip joint.
And why is that specific injury such a time-critical emergency?
Because of what's around the hip joint. The sciatic nerve runs right behind it and can be stretched or crushed. And even more critically, the blood supply to the head of the femur can be torn or kinked. If you don't reduce that dislocation immediately, within hours, you risk the bone dying from lack of blood vascular necrosis.
So the indirect mechanism creates a surgical emergency.
A ticking clock. Exactly. Now, moving to penetrating injuries with sharp objects, you need to know your anatomy cold. For a chest wound, you have to remember the diaphragm moves. In full expiration, abdominal organs like the liver and spleen can be as high as the fifth rib. A low chest stab wound can easily be an abdominal injury.
And firearms. What's the difference between a low-velocity and high-velocity round?
It's a whole different ballgame. Low-velocity bullets often act a bit like a knife, damaging tissue along their path, but high-velocity bullets, that's about physics. They cause massive damage through something called lateral acceleration. They create a temporary cavity that is vastly larger than the bullet itself.
The temporary cap.
Yes. It only lasts for milliseconds, so you'll never see it. But this huge pressure wave stretches and crushes tissue far from the bullet's actual path. It causes widespread cell death and drives bacteria and foreign material deep into the wound.
So the small entry and exit wounds are completely misleading.
Completely. Surgically, it means you have to do a very wide exploration and cut away all that dead tissue created by the temporary cavity. If you don't, the risk of a catastrophic deep infection is huge.
Okay, so after mechanism, we have to consider the patient themselves.
Of course. Age, body size. A car hitting a child pedestrian causes a very different pattern of injury than hitting an adult. And you have to use the power of the obvious clues.
Like the seatbelt sign.
Exactly. You see that linear bruise across the abdomen and the patient has pain. You have to be thinking about internal bowel or vascular injury or a specific type of lumbar spine fracture. Exposure, the E in ATLS, is there for a reason. You have to look for these clues.
But sometimes, as you said, the formula fails.
Yeah.
Let's talk about the hidden mechanism.
This is when the story you're being told is false, usually to hide criminal activity. The example in the text is a patient with a heel bone fracture who says he fell in a pothole. But the injury pattern is more consistent with a fall from a great height.
And he actually fell during a burglary.
Right. And if you believe the pothole story, you might just treat the heel. You'd fail to look for the associated injuries of a vertical fall, like compression fractures in the lumbar spine. The misleading history puts the patient in danger.
And this gets even more serious with vulnerable patients. A child or someone with dementia.
In cases of non-accidental injury, the history is almost always going to be inconsistent, or it will change over time, or it just won't fit the injuries you're seeing.
What are the big red flags for NAI in a child?
Long bone fractures in a baby that can't walk yet, that's a huge one. Injuries that don't match the story. And specific patterns, like posterior rib fractures from being squeezed. Our job is twofold. Treat the injury and protect the child by alerting the authorities. And you also have a forensic duty to try and preserve evidence where possible.
Okay, what about the other way the formula fails? Hidden patient factors.
This is when the mechanism seems way too minor for the injury you're seeing. That's when you have to suspect a pathological fracture. The bone was already weak.
From what?
It could be a cancer metastasis, osteoporosis, or a congenital disease like osteogenesis imperfecta brittle bone disease. If you miss a fracture through a tumor, you've missed the cancer diagnosis.
Or the injury could be a symptom of something else entirely.
Precisely. An elderly patient comes in with a broken wrist and a cut on their head from a fall. You can just fix the wrist. But what if they fell because they had a mini stroke, a TIA, or a new heart rhythm problem? If you don't do that medical secondary survey and find the underlying cause, you've failed them. You've treated the injury but not the reason for the injury, they'll just fall again.
So once you've been through the formula and you still think there might be hidden injuries, what are the next strategies?
There are two. Strategy one is the look everywhere approach. This is your secondary and tertiary survey, a meticulous head-to-toe exam repeated over time.
And this is where whole body CT has been a game changer.
A massive game changer. WBCT has massively accelerated the diagnostic process. It picks up things we used to miss all the time, subtle chest injuries, pelvic bleeds, cerebral spine fractures.
But it's controversial, isn't it? The radiation dose is significant.
It is. A single WBCT is about 12 to 16 millisieverts. That's equivalent to maybe 76 chest x-rays. Some reports link the liberal use of CT in the U.S. to 1.5 to 2% of all cancers, so it's not trivial.
So how do you justify that risk?
You justify it with the timeline concept. The small, long-term theoretical risk of cancer is massively outweighed by the immediate, very real risk of dying from a missed aortic injury or a brain bleed. The time saved by doing one fast scan can be the difference between life and death, but it means we have to be smart and have strict protocols for who gets one.
And the second strategy?
The focused exclusion approach. This is about knowing which injuries are missed all the time.
Which ones are they?
They're often subtle orthopedic injuries, fractures of the small bones in the hand or foot metacarpals, metatarsals, scaphoid fractures in the wrist, paralunate dislocations, posterior shoulder dislocations. These are notoriously hard to spot on initial x-rays.
So you need a high index of suspicion.
You have to actively hunt for them. If the mechanism fits, you have to get specific, dedicated imaging to prove they are or are not there. Missing them leads to chronic pain and disability down the road.
Right. So assessment is done. We move to the response, the treatment. And in a polytrauma patient, everything is unstable. You're trying to stop them from running out of their biological reserve.
Exactly. The immediate goals are all physiological. You have to reverse the shock and bleeding to prevent secondary organ damage and, critically, to stop them becoming coagulopathic, unable to clot their own blood.
And you have to keep them warm.
Yes. Hypothermia is a huge enemy. It's common from exposure and cold IV fluids, and it directly makes bleeding worse by impairing the clotting cascade. Just covering the patient is a vital intervention.
Fluid management has also changed a lot, hasn't it? We used to give massive amounts of saline.
We did. We used to drown them in crystalloids. Now we know that traumatized lungs just can't handle that extra fluid. It causes pulmonary edema. So the modern approach is much less crystalloid and much earlier use of blood products, red cells, plasma, platelets, to restore what's actually been lost.
The coordinated response starts with the paramedics calling ahead, triggering the trauma team.
Right. And in that team, the leader is the conductor. They have to prioritize. If you have a general surgeon who needs to stop a spleen bleed, a neurosurgeon for a head injury, and an orthopedic surgeon for an open femur fracture, the leader decides who goes first. And they have to be willing to break protocol if it's in the patient's best interest.
And these protocols, the nice embossed guidelines, they're not just bureaucracy, are they?
Not at all. They standardize care, reduce delays and errors, and they provide crucial medical legal protection when you're making life or death decisions in seconds. But there's a danger in them, too. The danger of incorrect labeling. If a patient is triaged and incorrectly labeled as a simple accidental fall, it can mask the real serious underlying problem and set them on completely the wrong care pathway. That first label is incredibly powerful.
So once the patient is resuscitated, we get to the big surgical strategy debate. For the polytrauma patient with multiple injuries, when do you fix the fractures?
The traditional approach was ETC, or early total care. Fix everything definitively within 24 hours. And for a long time, that was the gold standard.
But it had a downside.
A big one. In the sickest patients, those with major head or chest injuries or who were in deep shock, this aggressive early surgery seemed to make things worse. They developed higher rates of ARDS, adult respiratory distress syndrome, and multiple organ failure.
And this led to the two-hit hypothesis.
Exactly. The idea is that the initial trauma is the first hit. It primes the body's immune and inflammatory systems. Then, if you come in with a massive, long surgical procedure, that's the second hit. And in an already unstable patient, that second hit can completely overwhelm their biological reserves and tip them into fatal organ failure.
So the surgery, the thing meant to help, was actually killing the sickest patients.
In some cases, yes. And that realization led to the development of DCO damage control orthopedics or damage control surgery.
Which is a completely different philosophy.
A total shift. With DCO, the surgery is part of the resuscitation. Instead of a long, definitive fixation, you do a fast, temporary stabilization. You put on external fixators to hold the bones roughly in place. It's quick, minimally invasive, and designed to not be a major physiological stress.
So you control the damage, stop the bleeding, and get out.
Get out, get the patient to the ICU, get them warm, correct their acidosis and coagulopathy, and then days later, maybe 4 or 5 days later when they are stable, you bring them back for the definitive surgery.
But we need to be clear here. DCO is not for everyone.
Not at all. The vast majority of patients, probably 80 to 90%, are still best served by ETC. DCO is reserved for that small subset who are critically unstable, and the decision has to be based on clear, objective criteria.
Okay, let's go through those criteria. What are the red flags that tell a surgeon this patient cannot tolerate a big operation right now?
You're basically looking for the signs of the lethal triad of trauma: hypothermia, acidosis, and coagulopathy. So the specific criteria would be 1. Hypothermia, a core temperature below 34 degrees Celsius.
Really cold.
Very cold. 2. Acidosis, a pH below 7.2 or a really high serum lactate, say over 5. 3. Obvious coagulopathy. 4. Severe shock, so blood pressure consistently below 70. 5. Massive transfusion, approaching 15 units of blood. And finally, a very high injury severity score, over 36.
So if a patient ticks those boxes, you switch from an ETC plan to a DCO plan.
You must. Even if you're in the middle of the operation, you have to prioritize physiology over anatomy. Newer concepts like PRISM prompt, individualized safe management are all built on this idea of doing no further harm and tailoring the response to the individual patient's ability to cope.
And this all requires incredible planning. The team needs a plan A and a plan B.
Absolutely. The text suggests literally having a whiteboard in the operating room. Plan A is ETC, Plan B is DCO, and you write down the specific triggers that will make you switch. That way, if the patient starts to deteriorate on the table, everyone knows the plan is to switch, apply an X fix quickly, and get to the ICU.
It all comes back to monitoring those trends.
Always. You need protocols for charting vitals in labs so you can see the deterioration coming before it's a catastrophe. A good example is a pelvic fracture protocol. Based on stability and CT findings, it gives you a clear pathway. This patient goes to the OR for packing. This patient goes to interventional radiology for embolization. It removes the guesswork.
So finally, let's widen the lens. Trauma management doesn't end in the hospital. Clinicians have a role in prevention.
A huge role. By responding to the mechanism of injury. If you're a surgeon and you start seeing multiple patients with the same injury from the same location, the example is a faulty bridge, you have a public health duty.
You're the one who can spot the pattern.
Exactly. You can flag that pattern to the authorities, to the engineers, so they can fix the underlying problem. You can translate your clinical data into public health action.
And we also have a duty to respond to the patient factors, especially in vulnerable older patients.
Yes. We know they have a higher risk of fractures from low bone density. We know their risk of falling is higher due to things like poor vision or other medical conditions.
So the response isn't just to fix the broken hip.
No, the response has to be proactive. It's about starting bone protection therapy. It's about making sure they get their cataracts fixed to improve their vision. It's about treating the whole patient to prevent the next injury.
So to bring this all together, the core of trauma care is that three-factor formula. Mechanism plus patient equals injury. And if it doesn't add up, you have to dig deeper.
You do. Early management is all driven by ATLS and the timeline concept acting before the signs are obvious.
And the definitive surgical strategy is a careful balance, a choice between ETC for the stable majority and DCO for the critically unstable few, guided by those clear physiological red flags.
At the end of the day, trauma care is about constant vigilance. It demands systematic protocols and the resources to provide 24/7 care. The goal is always to restore stability and save a life in the fastest, safest way possible for that individual patient.
Okay, let's quickly recap the 4 critical takeaways you really need to carry forward from this. First, major trauma is a massive global public health crisis. It's defined by an ISS over 15, and its burden far exceeds many major infectious diseases combined. Second, the timeline concept is everything. You must intervene proactively, screening before signs. The difference between finding an extradural hematoma on an early CT versus waiting for the GCS to drop is the difference between life and death. Third, that three-factor formula mechanism plus patient equals injury has to be interrogated. Always hunt for covert injuries and be acutely aware of the possibility of misinformation, especially when you're assessing vulnerable patients for NAI. And fourth, modern surgical strategy hinges entirely on the patient's physiological state. That's what determines the switch between ETC for the stable and DCO for the unstable patient who is fighting that devastating two-hit phenomenon.
And as a final thought for you to take away, as you internalize just how vital these organized trauma systems are, I want you to think about this. Given the huge public health burden and the proven success of systems like Level I trauma centers, what broader societal investments, things like public health education, redesigning roads for safety, or targeted fall prevention programs for the elderly, do you think would give us the biggest and fastest reduction in trauma deaths? And how would the success of those prevention strategies feed back and maybe ease some of the immense pressure on our trauma hospitals? It's that balance, isn't it, between treating the crisis and preventing it from ever happening in the first